afternoon, and welcome to the Public Health Practice Grand Rounds for March 2011. My name's Molly Mitchell, and I'm the coordinator for the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome everyone to today's presentation on the healthcare worker immunizations, recommendations and challenges with Robin Decker and Brenda Roup. Just for those watching online, if you have questions at any point during today's webcast, please just click on the screen to send in an email for the presenters at any time during today's presentation. And before we begin today's presentation, I'd like to just draw your attention to some of our trainings that are available online. We have archived webcasts of every monthly public health practice grand round that we've ever done. You can watch those as well as training for public health nursing. And I just want to draw your attention to some of our trainings that are coming up that are face-to-face trainings, including our community assessment and formative evaluation training on March 25th, investigating environmental public health complaints on April 6th, and outbreak investigation fundamentals, a team approach on April 6th and 7th. And also be sure to join us next month for the April Public Health Practice Grand Rounds on syphilis in Maryland, populations at risk, on April 20th with Dr. Anne-Marie Rompolo. And with that, I'll go ahead and introduce today's speakers. We have Dr. Brenda Roup, who has served since 1999 as the nurse consultant in infection prevention and control for the Maryland State Department of Health and Mental Hygiene. She has more than 30 years of experience in infection prevention and control programs, has been certified in infection prevention and control since 1984, and has administered infection prevention and control programs in acute care hospitals ranging in size from 80 to 950 beds. She's done extensive consultation and continuing education on infection prevention and control issues in acute and long-term care settings, has published articles and book chapters relating to infection prevention and control, and has presented infection prevention and control research studies at international conferences. Dr. Roup is also a retired U.S. Army Nurse Corps officer. Dr. Roup received her B.S. in nursing degree from the Medical College of Virginia, Virginia Commonwealth University, M.S. in nursing degree from the Catholic University of America, and PhD in nursing and epidemiology / infection control from the University of Maryland at Baltimore. She also was selected to serve from 1995 to 1997 as a Johnson & Johnson postdoctoral fellow in infection control at the Johns Hopkins University School of Nursing. And Robin Decker is also joining us today. Robin Decker is currently the nurse consultant in the Center for Immunization in the Infectious Disease and Environmental Health Administration at the Maryland Department of Health and Mental Hygiene. She has a long-standing interest in immunizations and vaccine-preventable diseases and serves on the board of directors of the Maryland Partnership for Prevention. She's a graduate of the University of Maryland School of Nursing and a member of Sigma Theta Tau Pi Chapter, International Honor Society of Nursing. Since 1974, she has worked continuously in both the public-private sectors in a variety of settings and service areas with more than 20 years diverse populations in community settings. Her acute care nursing roles including CCU, medicine, and ophthalmology. She also successfully operated her own company for 8 years providing case management services. This wealth of experience gives her an understanding of the benefits and difficulties of implementing national recommendations. And with that, I'm going to turn the floor over to Robin.
Thanks, Molly. Good afternoon. Let me put the water away so I can't reach it and spill it. I appreciate the opportunity to speak with you for a few minutes this afternoon about healthcare worker immunization. I'll be talking about recommendations, and Dr. Roup will address challenges. This is the mission statement of the Infectious Disease and Environmental Health Administration at the Maryland Department of Health and Mental Hygiene. I work there in the Center for Immunization, as Molly said. So why do we immunize? Well, you know, Immunization is an essential part of any infection prevention and control program. You're probably aware of the notoriously low immunization rates among healthcare workers, in particular for influenza vaccination. In one season, influenza vaccination rates have not exceeded 49%, which is abysmal, really, for healthcare providers. So it's really not just personal. It's important for us to protect patients, our family members, and our co-workers, so we need to be vaccinated. Immunization has been called the most important public health intervention since safe drinking water. It saved millions of lives and prevented hundreds of millions of cases of disease. Smallpox has been eradicated worldwide. The last case occurring in the United States was in 1949. The last naturally occurring case was in Somalia in 1977. Polio, global eradication efforts are successful. The numbers for 2010 totaled 1,292 cases worldwide. And as of March 9th, 2011, only 51 new cases have been reported. Diphtheria is essentially non-existent in the U.S. except rarely. We had a case reported in 2003. A 63-year-old man visited Haiti to work in a rural village, and when he returned to Pennsylvania, he was hospitalized. He died 17 days post-initial exposure of diphtheria. And tetanus, 98% decrease in tetanus cases in the U.S. since the pre-vaccine era. Most recently in Baltimore County, we had a case in September. A 95-year-old lady, was injured when she scratched her arm getting out of her car. She died 17 days later. This is my herd. This addresses herd immunity. The vogue term is now community immunity. Diseases that can spread person to person, like measles, mumps, rubella, varicella, they're the kind impacted by herd immunity. Tetanus, however, is one that is spread through contact with contaminated soil or through contact with feces, so it's not impacted by how many folks around you are immunized. So a critical portion of the population needs to be immunized in order to protect those who are unable to be immunized because they're pregnant, immunosuppressed, or maybe just too young to get immunizations. And it actually depends on the host, the environment, and the infecting agent. Some infecting agents require a higher level of immunization than others in order for herd immunity to be effective. So we immunize because vaccines work. I'm used to having something in my hand. What healthcare workers are we talking about? Well, anyone in a healthcare setting who might expose patients or be exposed to vaccine-preventable diseases. It's not just employees, the doctors, the nurses, the therapists, the aides. It includes volunteers and other staff. Anyone who, as Dr. Roup likes to say, shares the air with patients. Why immunize healthcare workers? Well, there are reports ongoing of hospital-acquired infections. There are always new findings about transmission and lack of immunity against some vaccine-preventable diseases. New vaccines. We have 2005, tetanus, diphtheria, and acellular pertussis vaccine was licensed. Since then, we've had Zostavax, we've had human papillomavirus vaccine. There are new recommendations. Looking at the data, recommendations are modified. And again, I mentioned the low vaccination rates among many healthcare providers for certain recommended vaccines. Inpatient facilities, acute care, extended care, any residential setting, outpatient settings, all the clinic settings, private physicians' offices, homes, adult daycare settings, anywhere, health departments, lab staff, first responders certainly, nurses in schools. If you provide services to patients, then as a healthcare person, you need to be vaccinated. I'll talk a little about the vaccination recommendations specific to healthcare providers. In 1981, Occupational Health Administration, OSHA, mandated availability of hepatitis B vaccine to all people who might come in contact with blood-contaminated body fluids, but blood-contaminated products or body fluids. And occupational exposure obviously puts people at great risk for infection. The risk has decreased 90% with the advent of that recommendation in December 1991 and the implementation of standard precautions. Still, there are approximately 30% of healthcare providers who decline hepatitis B vaccination, which is, I think, a pretty high number. The numbers in 1983 were 17,000 new infections yearly, and they dropped by 1995 to 400 cases, and that number is believed to remain constant. HBV infection is very serious. If you have 400 new cases a year, approximately 20 of those people will go on to develop cirrhosis, liver cancer, and possibly need liver transplantation. So the recommendation for hepatitis B vaccination is we have 3 options here, 2 of which are likely to be done with healthcare providers. And you'll hear me use healthcare providers and workers interchangeably, so just forgive me, follow with me. Single antigen, 3 doses given at 0, 1, and 6 months. That means day 1 is 0, 1 month after the first dose, you give the second dose, then 6 months following the first dose, you give the third dose. The combination vaccine, there's one brand that combines A and B. You have 2 dosing options with that. You have a 3-dose option, again at 0, 1, and this can be given at 6 to 12 months, or 4 doses given at 1, 7, 21 to 30 days, and 12 months. In any series, that final dose is critical to maximizing immunogenicity. The 4-dose option is generally reserved for people who are at higher risk of contracting hepatitis B. That would be people, for example, who are injection drug users, people in correctional facilities, people that you're not as likely to be able to get to return for those follow-up doses. So even with this dosing option, with the 3-dose on the A and B vaccination combination, you want to take advantage of getting that person back as soon as you can for that 3rd dose. That's always important in maximizing your vaccination rates. So for healthcare workers specifically, well, let me just say generally that if a person comes to you as a healthcare worker, volunteer, if you have a student working for you, if they bring with them documentation that they have had the recommended series, or you'll see what the other acceptable criteria are here in a few minutes. If they bring documentation, you don't need to do anything. You don't have to do titers, just keep the documentation, and that's acceptable. Excuse me. For hepatitis B, if a person comes to you and they have complete documentation, as I said, that's all you need to worry about. If they have not completed the series, you need to, either your occupational health group or if you have someone else you enlist to do it, complete that series. Whether they've had 1 dose 10 years ago or 2 doses 15 years ago, you just provide the 1st or 2nd or 3rd dose, whatever they need to complete the series. You don't start over again. At the end of completion of the series, 1 to 2 months, use that window to test for hepatitis B surface antibody. If they are 10 million international units per milliliter or greater, then they're considered immune. If it's less, then you need to repeat the series. When you repeat the series, you do the entire 3-dose series. The reason that is recommended versus 1 booster is that you're likely to get, with one booster, about 20% more of those folks who will respond, who will have an acceptable antibody rate. And if you give a full 3-dose series, you'll get as much as 55% response rate. So that's important. If after the second series they don't respond, then they're considered susceptible and they should be counseled accordingly. It's possible they're already infected. They might need to have a hepatitis B surface antibody done and possible treatment initiated. Recommendations for influenza. For everyone 6 months and older, unless it's contraindicated, the recommendation as of the current influenza season, that's our 2010-11 flu season, is that, as I said, everyone get vaccinated. Studies have documented the benefits of vaccinating healthcare personnel. It reduces transmission of influenza in patient care settings, and it decreases illness and absenteeism rates among your healthcare workers. So it's important. There was a sero survey done at one institution during a mild influenza season, and 23% of the workers tested showed that they had evidence of influenza infection. 59% of those could not recall having flu, and almost a third didn't even remember having any kind of respiratory infection. So that suggests a very, very high incidence of asymptomatic illness. So if you're one of those folks who says, well, I don't get the flu shot because I never get the flu, then you really could be infecting someone who is at great risk of having problems due to the sequela of influenza infection. Recommendations: trivalent influenza vaccine, TIV, or the injectable, for everyone ages 6 months through adulthood who can't get the live attenuated influenza vaccine and for whom flu vaccine is not contraindicated. You give 1 dose annually. There is a different situation. We're talking about healthcare workers who are adults, but for children, there is a recommendation for those 2 through 9 who have never been vaccinated before or who had only 1 dose in the previous season to get 2 doses. But put that aside, healthcare workers are adults. Live attenuated vaccine is for healthy persons who don't have a medical contraindication that increases their risk for complications of flu. It's for healthy, non-pregnant persons 2 through 49. If they have any of the contraindications like chronic respiratory problems or cardiac problems, etc., if they're in that long list of people for whom flu vaccine is absolutely indicated, they need to get the injectable vaccine. So LAIV is for healthy, non-pregnant people 2 through 49. You give 1 dose intranasally annually, and that too, what I mentioned about the children applies here in this situation. The exception is that healthcare workers who provide care to people in, say, a bone marrow transplant unit in reverse airflow settings should get TIV and not LAIV. And just an aside, we often get the question, can pregnant healthcare workers administer LAIV? Yes, they can. They can administer any vaccine except smallpox. MMR vaccine recommendations. This is, I mentioned the ACIP before. These are ACIP presumptive recommendations for presumptive evidence of measles, mumps, and we address rubella on the next slide. These are still provisional, meaning they have not been published officially in an MMWR, but the DHMH, Department of Health and Mental Hygiene, does follow ACIP recommendations, whether they're final or provisional. So for measles and mumps, documented administration of 2 doses of live measles virus, or measles, should have measles and mumps, pardon me, laboratory evidence of immunity or confirmation of disease, or birth before 57, and I'll talk about that in a minute. For rubella, documented administration of 1 dose and laboratory evidence of immunity or confirmation of disease, or birth before 57, except women of childbearing age who could become pregnant. Notice 1 dose for rubella, 2 for measles and mumps. And I'll point out here that single antigen measles, mumps, and rubella vaccines are no longer available in the United States. They became, mumps has been unavailable for about 2 years, and measles and rubella now for about the past year. MMR vaccine recommendations, I said I would talk about that asterisk. Birth before 1957 in itself might not be sufficient evidence of immunity. If there's an outbreak, they need to have the recommended number of vaccinations. Therefore, measles, mumps, or rubella, except for rubella, if they have 1 documented dose, they're okay, but for measles and mumps, they need 2. The healthcare facilities, even though it's not absolutely recommended, should really strongly recommend it in their own staff. Varicella vaccine recommendations. There was a situation documented in 2006 where 4 medical students ended up with varicella. They were exposed doing an autopsy. There was blood that splattered. There was no attempt made to wash anyone off or determine their immunity status at that point. Varicella serologic proof of immunity, prior vaccination with 2 doses, verified history of varicella disease, or a history of shingles. Because if they have shingles, they've either been vaccinated or they had varicella. Also, you can test, again, obviously it's one of the acceptable criteria for immunity, but it's not recommended that you test after administration of varicella vaccine. The tests that are generally available are not consistently sensitive enough to detect vaccine-induced immunity. Tdap, tetanus, diphtheria, and acellular pertussis. This is a recommendation that was made by the ACIP in 2006. Healthcare personnel in hospitals or ambulatory care settings who have direct patient contact should receive a single dose of Tdap as soon as feasible if they have not previously had a pertussis-containing dose. You all are familiar, I'm sure you've heard about the California pertussis outbreak. The 2010 preliminary data show they've had the greatest number of cases reported since 1947. They had during 2010 almost 8,400 cases reported. 63% of those cases were confirmed, and the probable and suspect cases were just about an even split among the remaining numbers. There were 10 reported deaths. 9 of those were infants under 2 months of age who were too young to have started their vaccination series. This really amplifies the importance of having people around infants immunized, not just healthcare personnel, but anyone. In fact, I'll take a second here to talk about an initiative. Department of Health and Mental Hygiene is fortunate to work with the Maryland Partnership for Prevention. We have the executive director, Tiffany Tate, here in the audience today. We work with them. Many of our initiatives it's far-reaching. This one is not specifically targeted to healthcare providers, but involves healthcare providers as our partners, because the focus is immunizing women postpartum who have not yet been immunized with a pertussis-containing vaccine, and anyone who's going to be around that infant. So if you're interested in this or some of the other initiatives I'll be talking about in a few minutes, please contact the Center for Immunization at 410-767-6679 or Google the Maryland Partnership for Prevention. Oh, by the way, that last child, the 1 out of the 10, was just, I think, about 3 months old and had only one pertussis dose in the series. This is a continuation of the 2006 MMWR recommendations. This describes the CDC definition of who is included. Physicians, etc. It's just not limited to all of the professional staff involved in caring for patients. It's all the people who come into contact with them. You can see social workers, chaplains, clerical people. We should include maintenance people, vendors, anyone who's going to come in contact with that patient. The Joint Commission recently released a monograph that addresses Tdap vaccination strategies. And they cited that that vaccination coverage of healthcare workers in 2008 with Tdap was at about 16%. So we have a whole lot of work to do. Tetanus, diphtheria, pertussis vaccination for adults less than 65. If there's an incomplete series or there's no history of vaccination, then you either give a complete series or complete the series that was already started. Remember, you don't have to restart it. 1 dose at 0, 1, and 6 to 12 months. And again, take advantage of that 6-month opportunity if you can get someone back quickly. You boost every 10 years, and the current recommendation is only 1 Tdap, but that may well change as soon as more data is gathered. Oops. Sorry. Adults 65 and older. The FDA has licensed Tdap for use in people in one vaccine brand. It's 10 through 64, and another is 11 through 64. So this recommendation is actually an off-label recommendation. In California this summer, the Department of Health recommended this use because of the pertussis outbreak. In Canada, it's been used off-label in people 65 and over, and also in a group of children. We previously had no recommendations for pertussis-containing vaccine for children 7 through 9, so that created some problems. Canada's been doing it for years, though, and data do not show any increased adverse reactions in these people in the off-label groups. So again, if you're going to have contact with an infant, definitely get it. And any other adult over 60 or 65 or over who wants to be immune and protect others. Timing, this is critical, not just for healthcare workers anymore, as the recommendation from 2006 stated, but it can be administered regardless of the interval since the last tetanus or diphtheria toxoid containing vaccine. I can't stress that enough. Some physicians are still very uncomfortable with that recommendation. So if you have someone who is uncomfortable, you can refer them to the CDC. They can look at the MMWR that was released in January of 2011, January 28th, which clearly discusses that. Meningococcal vaccine is recommended for lab workers only. And one of the resources, you may have gotten the links that I sent to Molly, one of the resources we use often, which is a 1-page healthcare worker vaccination recommendations in brief, does not address revaccination of people who remain at risk, but that is an important new recommendation, and that is that if they remain at risk, they should be revaccinated in 5 years. For ages 2 through 54, use meningococcal conjugate, and 55 and older, use meningococcal polysaccharide. I mentioned a couple of other initiatives that we're involved with MPP. This initiative, the Healthcare Worker Vaccination Initiative, is in its 6th year. It started out as the Healthcare Worker Influenza Vaccination Initiative. And 2009, we began to introduce more information about overall healthcare worker vaccination recommendations. And then officially this last season, 2010-11, we dropped influenza and it became vaccination initiative. As you can see, the goal is to raise vaccination rates among healthcare workers. And support is provided, MPP provides resources to support people in their vaccination campaigns. There have been lots of creative things that have been done. It could be a provider office, it could be an agency, it can be a health department, a hospital, any long-term care facility. If you have a question, just call and find out whether or not you're eligible. It's a little late to join for this year, but do think about it next year, usually in the late summer. The information is sent out. And then there's a reward banquet. People actually get awards. They're recognized for their efforts. It's well received. And this is a new initiative, the Maryland Healthcare Worker Immunization Best Practices Challenge. This is designed to inspire and reward exemplary practices in vaccinating healthcare workers. MPP is providing grants up to $15,000. That's huge. At least to us it is, to start, refine, and/or continue campaigns to vaccinate staff and volunteers against vaccine-preventable diseases. This initiative aims primarily at non-flu programs, since we have our other. Now, before Dr. Roup speaks, I just want to make two important points, just to reinforce this. You need to be sure that you have documented the immunity status related to vaccine-preventable diseases addressed in these recommendations. Document that status for all of your staff. And for people who decline vaccination, who are not immune, you want to be sure you revisit that topic on a regular basis. So maybe during the year when you have your flu campaign, consider that. Dr. Roup?
Good afternoon, everyone. Please excuse my glasses, but I need them to read. I'd like to thank the Mid-Atlantic Public Health Training Center for inviting us here today, and thank you, Robin, for that thorough overview of the immunizations that are recommended for healthcare workers in Maryland from the CDC's Advisory Committee on Immunization Practices. Now, you see on this, whoops, it would help if I put the next slide up. We consider healthcare worker immunization to be one strategy towards the ultimate goal of patient safety, and that is a good way for us to think about it, because we are looking at the employees, but we're ultimately focusing on the patients and the communities as well. Now, in my experience, and perhaps in yours as well, this overview that Ms. Decker has given us of immunizations, there's an enormous amount of variability in how facilities and agencies of healthcare in Maryland deal with the challenges of immunizing their healthcare worker workforce. Now, I am going to talk about the challenges, but I'm speaking about all healthcare settings and agencies, not just hospitals or long-term care. I'm talking about home health care, physicians' offices, freestanding facilities such as ambulatory surgery, dialysis, group homes, all of these places where health care is given, our recommendations apply to. But before I go into those challenges this afternoon, however, let me say that, in my opinion, the success or failure of a healthcare worker immunization program is directly correlated with the amount of emphasis placed upon that program given by the facilities or health systems, what infection preventionists like to call the C-suite. Now, when I'm talking about the C-suite, I'm talking about that location in a building, a headquarters building or a hospital, where you have the chief executive officer, the chief operating officer, the chief finance officer, the chief medical officer, the chief information officer, and so forth and so on. So all those C's equal to a C-suite. and IPs, infection preventionists, like to refer to that that way, and by the human resources. Human resources must be a part of this process. Infection prevention and control programs and employee occupational health programs place great emphasis, of course, and spend enormous amounts of their time and energy on healthcare worker immunization. But without the visible, not just tacit, but visible support from the folks upstairs, these efforts are frequently met with results that are lackluster or mediocre at best. I wanted to put up this disclaimer. These opinions and suggestions are mine, based upon a literature review and position statements, numerous position statements of professional healthcare organizations, and these opinions and suggestions do not represent official policy of the Maryland State Department of Health and Mental Hygiene. Now, these suggestions and recommendations, again, as I said, are founded on a substantial body of literature which demonstrates rather conclusively that healthcare workers who are immunized against or otherwise immune to measles, mumps, rubella, varicella, hepatitis B, tetanus, diphtheria, pertussis, and influenza not only see their own morbidity decrease, but positively affect the patients they care for by not transmitting those infections to them. So let's turn now to challenges. And again, I'm speaking of all immunizations. As Robin said, we're not just focusing on influenza here. We're talking about all immunizations for healthcare workers in all healthcare settings. So what are these challenges to getting healthcare workers immunized to common vaccine preventable diseases? Now, I've distilled the challenges found in the literature down into what I consider to be 5 overarching concerns that need to be dealt with by the facilities or the health system's CEO, human resources, infection prevention and control and occupational health programs, safety and health programs, and any employee representation such as unions or collective bargaining units. Representatives from all of these areas must be at the table to design and enforce these healthcare worker immunization programs. So these challenges appear to boil down to vaccine supply, challenges related to fears about vaccine safety, challenges related to the lack of knowledge regarding the epidemiology of vaccine preventable diseases. That's not usually listed as a challenge, but it pervades the literature. Another challenge is, of course, the big one, healthcare workers' refusal to receive vaccines. And finally, cost of vaccines to employees is a challenge. Now, I'm only going to offer 1 or 2 suggestions for you to think about for each of these challenges, but it should give you a framework to direct your thinking about your healthcare worker immunization program. So, challenge number 1, the vaccine supply. Production issues can usually result in either decreased amounts of doses or decreased delayed delivery of doses, or both. Now, unfortunately, this is generally something pretty much beyond our control, and we can only really react to it. So I'll talk in a minute about something you might be able to do about it, but 2 good examples of this were 2003 and I believe 2004. Somebody please correct me later if I don't have the dates right. A huge influenza vaccine shortage, and of course we had come out with all of our recommendations, and lo and behold, the vaccine was short and late, and we had people lined up around the block for all over the place. Another one, which I found extremely interesting, was in 2007 and 2008, shortly after, a few months after CDC came out with its rather new recommendation that all healthcare workers should get a Tdap vaccination instead of one of their TD doses. There was a Tdap shortage, right? So we really can't do a lot about that. But we can do a little something about it. And one of the primary things we can do is to stratify healthcare worker groups according to risk factors that increase the likelihood of their getting the infection. The best example I can think of is to say, for example, Tdap vaccine should go first to emergency department personnel and pediatric staff, because those are the persons who would most likely be in contact with a child who would have pertussis. Challenge number 2. This is also a big one. Fears about vaccine safety. There are fears about side effects of the vaccine. There are fears about the vaccine, quote, causing, unquote, the disease it is meant to prevent. Of course, we hear this most often with the influenza vaccine. I can't get the flu vaccine because it'll give me the flu. It's interesting because have you ever heard anyone say, I can't get the hepatitis B vaccine because I'll get hepatitis B? Have you ever heard anyone say, I can't get the measles vaccine because I'll get the measles? Right? I've never heard anyone say that in relation to any immunization except influenza. And urban myths and misunderstandings fueled by the internet. And of course, also certainly by rumor and coworkers and peer pressure and so forth, but the internet plays this monstrous role. If you go on and Google on urban myths related to influenza immunization or vaccine, you get thousands and thousands and thousands of hits. It's amazing, the stuff. Sometimes I will just go Google and read about some of the stuff that's on the internet about how you should never have a vaccine against anything, that it will kill you in the long run, it'll give you cancer, it'll give you this, it'll give you that. It's amazing. And yet, as an aside, I will tell you, a few years back, the Centers for Disease Control released a list of the 10 most life-saving public health measures in the last 100 years, and immunization topped the list. Okay? Interestingly enough, seatbelts were number 2, but in terms of lives saved, but immunizations topped the list. So what can we do about this? Continue with education, 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 and champions among facility staff. You just keep putting the facts out there. Every vaccine has a VIS, a vaccine information statement that goes with it. These are, I think, by federal regulation or law, must be written at a lower level, grade level, so they're easily understandable. You can use those VISs not just to hand to somebody after they've gotten the vaccine, but you can use them for education. Anything you can do to educate people about vaccine preventable diseases. In terms of champions, champions, of course, are usually defined as those individuals in a facility or an agency who are in positions of power and authority. They can be immunized and agree to serve as role models for others, and it can be a really great force. For example, if you can get all of your CEO, CFO, CMO, and all those C people, if you can get them down in the facility lobby, like the hotel lobby, and make it a media event and make sure they all get their, say, influenza immunization, that can have some impact on folks in terms of saying, okay, well, this is a top-down effort, okay, so these folks are getting it. Another thing that I think is extremely powerful that I don't think people use enough is peer pressure in the work setting. We all know that in a work area, in any work area actually, there are individuals that may not have an organizational role that carry authority with it, but for some reason they seem to have an enormous amount of influence over the attitudes and the opinions of the people that they work with, okay? If you can identify those people and get them on your side in terms of immunization, then you can probably get a lot more healthcare workers immunized. Challenge number 3, healthcare workers' lack of knowledge of epidemiology of vaccine preventable diseases. Excuse me while I wet my throat. Now, this may seem surprising, but I see it over and over and over again. We all do at DHMH and local health departments. Lack of knowledge of the chain of infection. Lack of knowledge of the fact that one single thing is not going to cause an infection, that it takes a chain of events for that to happen. Lack of knowledge of routes of transmission, lack of knowledge of incubation periods, length of infectivity, and so forth. Healthcare workers have a real lack of knowledge about these things. Why? Why should this be so? Probably because we no longer live in a world where we are surrounded by infectious diseases all of the time. So education about these common vaccine-preventable diseases is frequently either not done or glossed over or just given very short periods of time. And also, too, along that same lack of knowledge about epidemiology, healthcare workers are notorious for working when they are sick, okay? Notorious for this. Most of them either forget or never knew that these vaccine-preventable diseases are, by and large, most infectious before symptoms appear, or when the first day or so of being symptomatic. So they've already infected a large number of people. This is certainly true of influenza. A large number of people by the time they feel sick. So what do we do about that? Innovative education strategies. Again, here we are with the education. One thing that I had heard suggested that you'd have to coordinate with your information technology folks on computer terminals throughout the facility or the agency. You can have scrolling factoids about did you know, and then something about measles, something about mumps, something about pertussis, what's going on pertussis in California. And did you know, little factoids all the time about vaccine-preventable diseases, the epidemiology and the vaccine. You can offer things with continuing education credit, contact hours for nurses, continuing medical education credits, so forth and so on. You give them continuing credits and feed them, and they will come. Isn't that the saying, right? You can also have teaching rounds. You can have short videos that are constantly playing on computer terminals, and of course the usual literature and brochures. But you need to be as innovative as you can possibly be when dealing with that lack of education. All right, number 4, healthcare worker refusal to receive vaccine. Now, if you as president and or CEO have committed your facility or health system to have a healthcare worker workforce that is as safe as possible for your patients, and that one of your strategic goals is to have a workforce that is immune to all common vaccine-preventable diseases, then this is the major hurdle you have to overcome. And how will you do it? Well, first of all, CEO, C-suite, so forth, human resources administrative support is absolutely crucial. Absolutely crucial. The refusal to be vaccinated against any of these healthcare worker immunizations should have consequences. The refusal should have consequences attached to it. Now, there are several ways that you can do this. The first, of course, is declination forms that are placed either in the employee's medical or personnel file. Now, most, if all of you actually, should be used to dealing with this. OSHA has required a declination form if you decline the hepatitis B vaccine and work in an area in which you were exposed to blood or body fluids, to be placed in the employee's medical file for the last 20 years. So most places should be used to dealing with declination forms. Masks, or requiring unimmunized healthcare workers to perform certain actions when around patients, such as wearing a mask, okay? Also, you can have persons wearing tags on their ID badges or lack of tags on their ID badges to set them apart, as it were, to say, no, they have not had these various types of immunizations. Finally, of course, is to make the immunizations a condition of employment, with the exceptions of those with documented, and I mean underline that, documented medical exemptions. We have several health systems in Maryland that have made receiving the influenza immunization mandatory and as a condition of employment as of last fall, 2010. Generally, the implementation of these policies has gone very smoothly for these health systems, and only a relatively few employees have had to be terminated. The largest of these is MedStar, MedStar Health Systems has 9 hospitals in the Baltimore-Washington corridor, greater than 25,000 healthcare personnel, and 4,000 affiliated physicians. They have achieved influenza immunization rates of 99.9% of their healthcare workers and 93% of their affiliated physicians. You can read all about it in an article that was just published online. The journal is Infection Control and Hospital Epidemiology, which is the official journal of the Society for Healthcare Epidemiology of America. It is in the April 2011 issue. It's online. It's not out in print yet, but it's online. The title of the article is Championing Patient Safety Through Mandatory Influenza Vaccination for All Healthcare Personnel and Affiliated Physicians. That is in April 2011, volume 32, by Karen Fell, Bauner, Hofader, and Thomas. And I'll repeat that for you later if you want me to. But they go into detail about how that was achieved and all the people they brought to the table. So it can be done. It can be done. And finally, challenge number 5, the cost of vaccine to employees. This is a relatively easy one to deal with. The body of literature on healthcare worker immunization suggests that you meet with the greatest success if the employer offers all testing for immunity, and meaning serologies, and vaccines free of charge to the employee. You end up doing something like putting your money up front, okay? And if you have decreased employee sickness as a result of your employees being immunized, you don't have to call in temps, temporary personnel from a temporary agency. They always cost more. Or you don't have to furlough somebody with pay who has been exposed to a patient with a vaccine-preventable disease. So you save money that way. So in the long run, of course, you do end up saving money. So in summary, our patients deserve to be cared for by healthcare workers who are immune to common, communicable, or vaccine-preventable diseases. To reach the goal of an immunized healthcare worker workforce, a variety of challenges await, and the hardest of these can be overcome with strong, consistent support from the administrative C-suite and human resources. Now, thank you, and Ms. Decker and I are happy to discuss any questions you might have.
Thank you very much, Dr. Roup and Ms. Decker. This is the time in the program for us to take questions and answers, both from our live audience as well as those watching online. If you are watching online, I just want to let you know we have a separate email address for you to send your questions to. We're having problems with the Training Center email. So please send any questions to mmmitchel@jhsph.edu. And again, that address is mmmitchel@jhsph.edu. And so now we can take questions from our live audience right here.
Yeah, this is actually a comment. Just interesting information about the pertussis outbreak. I was at the National Foundation for Infectious Diseases clinical vaccinology course back in November, and they had Dr. Alexander from Chicago, who's a pertussis expert, speak. And one of the points that he brought up, which I thought was interesting, and I believe he's going to publish it, is that about 15 to 20% of adults who have been coughing for more than 2 weeks were PCR positive for pertussis and did not know. And that just speaks to the whole thing about vaccinating the parents' generation and the grandparents' generation and healthcare personnel, because they don't even know they're exposing susceptible children to pertussis, which is much more dangerous to them.
Yeah, thank you. I think that it's Dr. Alexander
Kenneth
might
Alexander.
be speaking at the National Immunization Conference upcoming in about a week and a half. So thanks.
Okay, do we have any other questions here today? Comments? Okay. I'm just waiting. I wanted to give people a minute to send their emails to this other address. If we have no other questions. Yeah.
Do you know what percentage of medical institutions require complete vaccination at the time of acceptance of a position?
No, I don't. That is one way, certainly one way to approach it. I'm guessing now when I say this, but from my interactions with Maryland's acute care infection preventionists, all of the hospitals require an immunization review when that person is hired. And I believe that most of them do require immunity to at least MMR and varicella and Hepatitis B. But I don't know that.
Pertussis.
Not yet. Not yet. That is still considered to be a relatively new requirement. I think most of them are trying to get their emergency department and pediatric staffs immunized. But as for everyone else, I don't think so. But you know, again, I don't know that for a fact because we don't collect any data on it.
I don't, but the Immunization Action Coalition, I think in their, not every week, in their IAC Express newsletter, does talk about the number of people who've now enrolled with them who are requiring, hospital staff requiring immunization. And they probably have a breakdown nationally. I just don't recall what it is.
Do you know if there are any medical facilities that have as part of your contract renewal, in your contract renewal, that you can vaccination that year? You can require people when they come in, but getting them to continue getting their vaccination.
Probably an increasing number are probably going to add it. This is really, it was not up. An increasing number are probably going to add it. This is becoming, now that we do have, published experiences showing that it can be done. You just bring all the right people to the table. I mean, they didn't accomplish this, MedStar didn't accomplish this overnight. They started working on this years ago, okay? But they brought all the elements together and lots and lots of education, lots and lots of advanced notice, that type of thing. So it's Adventist Health System is also another system in Maryland that started to require it last fall. Of course, they're not as large as MedStar, but they are the other big one. There are other big facilities in Maryland that stop just short of making it mandatory and do that second thing that I mentioned on the slide, is if you have turned down the influenza immunization, you must wear a mask within 6 feet of a patient. So I think the general trend is we are moving in that direction. So
Is there any reason I can't name a hospital, an institution?
I don't know of any reason.
Just want to be sure.
Why are you asking me?
Well, I don't know. You're here with me. You're partner in crime. One of our large healthcare facilities in Baltimore County, the Greater Baltimore Medical Center, had a 100% vaccination rate for influenza this year. And I believe, not absolutely sure, I believe that they lost only, I'm thinking 7 people, either through termination or resignation.
Right.
So we really are seeing more and more of this, people jumping on the bandwagon.
Right.
Some hospitals are still reluctant to require it, but more and more are saying, this is it.
One of the things that MedStar discovered, which you'll read in the article, when you look it up, is you hear a lot of people say that they're allergic to the influenza immunization or other kinds of things. Out of 25,000, there were, I think, 125 documented medical reasons, exemptions. Out of 25,000 people, only 125 could bring a note from their doctor saying that they couldn't have it. So the condition is not nearly as widespread as people think it is. So
It will move ahead. I can cite something I meant to speak about when I was talking. A measles outbreak in Arizona in 2008. At 3 hospitals, almost 8,000 healthcare personnel were exposed. 25% had no documentation of immunity, so they were serologically tested. And 30% were born before 57, and 5% were susceptible. 70% were born after 1957, and 11% were susceptible. So obviously there was a big gap there in knowledge of their immune status. So hopefully we'll begin to see one of the things that's on the to-do list at DHMH, or rather in the Center for Immunization. I shouldn't commit everyone. Is to work more closely with our institutions of higher learning here in Maryland and any programs where healthcare staff are trained so that they can be sure that they know what the immune status is and not over-test, not do more than they need to do. I think I briefly mentioned that. But we do have places who call us saying we have a student, or a parent might call and say, my daughter had documentation of her hepatitis B vaccine series. She's in this nursing school, and they're requiring her to start the series again because when they tested her, she showed no immunity. So we want to educate people about that so that we have a nice balance of what's happening out there.
I'm not sure if you have this data with you, but I'm wondering, it seems that we are hearing more and more about pertussis outbreaks, and I'm wondering if you could speak on what the vaccination rate is for the infants in the state of Maryland, and if you're seeing a decrease in families vaccinated, or how you handle the ones that won't vaccinate.
First of all, the epidemiologists in the Center for Immunization closely monitor any reported pertussis cases and work very closely with the local health departments. Maryland has not seen an increase in pertussis cases. I believe there's been a slight increase in Pennsylvania. I believe there has, but we're watching things very closely. With regard to the immunization rates, certainly we were number one in the U.S. 2 years ago, Tiffany, regarding our immunization rates for children up to 36 months. Okay, so high immunization rates. It's easier, of course, to make sure those rates are high once children are entered into daycare or school because of state requirements that are in place. But we really continue, the Maryland Partnership for Prevention is always working on initiatives to try to put that out there, the importance of immunization. How can we educate people? Our local health departments do a wonderful job. The private providers involved in the Vaccines for Children program do a great job immunizing those kids. So we have high vaccination rates among our children in Maryland.
If I can emphasize again, and kind of alluding to what Robin just said, in my experience, and I mentioned this at the beginning of my remarks, the variability in immunization rates, especially influenza immunization rates, among, say, for example, acute care hospitals in Maryland, okay, it truly is directly correlated with the emphasis on immunization of their healthcare worker workforce by the administration. It really is. If the administration has decided that immunization is one strategy towards the goal of patient safety, and our number one goal in this business is to keep our patients safe, then immunization plays an enormous role, and everybody is aware of it. Everybody knows they have to go and be tested or get their immunizations and that kind of thing. And in other acute care facilities in Maryland, it's not a priority at all. And you can see that when you see their immunization rates. You can see that it's not a priority at all. So it definitely depends. Infection preventionists and occupational health nurses can only do so much. Mm-hmm. They have to have administrative support. So.
Okay. We do have some questions from our online audience. And this is a question from Portland, Oregon. How have non-Western myths of immunization been addressed when they view research-based education with suspicion?
Say that again.
How have non-Western myths of immunization been addressed when they view research-based education with suspicion?
No.
I think that you can be sometimes very, very innovative in terms of education, and that's really all I can suggest at this point.
Yeah.
I think that sounds like the kind of thing if you have someone who simply is not going to believe what you say, regardless of what you say, you just try to be as innovative as you can. That's the only way I can think of to answer that.
Okay. And then we also have a question about pertussis. If a 50-year-old healthcare worker had pertussis infection about 2 years ago, do they need a DTaP vaccine? And if yes, when or how often?
I do believe it is recommended, even if you have had documented pertussis. Dr. Wilson, please correct me if I'm wrong. That does not necessarily confer lifelong immunity. Is that correct? Okay, yeah. So timing-wise, if the person had it 2 years ago, rather, I would say now's the time to get that Tdap vaccination.
Okay. And then we also have a question about TB skin testing. Please shed light on TB skin testing for staff if this is appropriate for the viewing audience at this time.
Well, I would say our TB staff would need to address that question. I thought it was going to relate to vaccinations, but
Yeah, it's not really relevant.
Okay. Okay. Do we have any other questions from our live audience? If not, then I think that ends our presentation for today. I really want to give a big hand and thank you to Dr. Roup and Ms. Decker for joining us today. And again, we hope that you all will join us again next month on April 20th for our presentation on syphilis in Maryland. Thank you very much.